Well, good morning or good afternoon, everyone. This is Stephanie Arnold-Pang, and I'm the Director of Policy and Communications here at the National Coalition of STD Directors. Welcome to our webinar, PrEP 101 for STD Directors. We are glad that you were able to join us for this important topic today. Just a few items of note before we begin. All participants are in listen-only mode, so please use the chat function to the left of your screen for any questions you might have. In addition, this call is being recorded, and both this recording and the presentation slides will be available after the webinar. So with that, I would now like to turn it over to Bill Smith, the Executive Director of the National Coalition of STD Directors, to give us a short welcome.
Good afternoon, everyone. I'm glad we have a very good crowd here. I'm looking at the participants joining, and I'm seeing that I saw many of you last week at the National STD Prevention Conference in Atlanta. So I'm so thrilled you're able to join us after a very busy week, and the rest of you as well. Just very briefly, NCSD is really pleased to be putting together this webinar this afternoon. We believe here at NCSD that working together with our HIV partners strengthens sexual health outcomes, and this is particularly the case when it comes to HIV and AIDS and PrEP. We believe, and there's some additional early evidence to suggest, that STD programs, and in particular STD clinics, can play an important role in scaling up HIV prevention by offering PrEP and other new biomedical interventions that we know can prevent disease transmission. But we also know through some of those same experiences that there are challenges on many, many levels. So I believe that we have assembled today an incredibly top-notch trio to provide our NCSD members across the country with a really great overview of PrEP. And I would say it goes a little bit beyond a 101 because I've seen a number of these presenters present before, and I am assured that you're going to get more than a 101 and that this conversation and webinar will get you thinking. So I should also just thank Jenny Sewell, our project officer from the Division of HIV/AIDS Prevention, who is also on the line with us. This particular webinar is being sponsored through a cooperative agreement that we have on policy work funded by both the Division of STD Prevention and the Division of HIV Prevention. And again, we're grateful for their support and the ability to provide this webinar today. Okay, so I am really thrilled, again, with the trio that we have lined up today. Dr. Dawn Smith from the Centers for Disease Control and Prevention will be our first presenter. Dr. Smith, I was so thrilled that I got to see you do grand rounds recently, so I'm really looking forward to your presentation today and glad you can join us. Dr. Charlene Flash from the Baylor College of Medicine will also be presenting today, as will NCSD's good friend at the Denver Department of Public Health, Dr. Mark Thrun. So without further ado, I will thank Stephanie and my amazing policy staff here at NCSD for making this happen today. And again, thanks to everyone for joining us.
Great. Thanks, Bill. So our first presenter is Dr. Dawn K. Smith, who is a medical epidemiologist at the Division of HIV/AIDS Prevention at the U.S. Centers for Disease Control and Prevention, where she serves as a biomedical interventionist activity lead in the epidemiology branch and conducts research and program activities supporting the implementation of daily oral antiretroviral pre-exposure prophylaxis and other biomedical interventions to reduce rates of new HIV infections in the U.S. So with that, please, Dr. Smith, please take it away. Dr. Smith, are you still with us? All right. I think I'm going to unmute the lines just to make sure that we have Dr. Smith still with us.
The conference has been unmuted.
Yeah, I'm still here.
Okay, great. Please go ahead. I'm sorry for that technical difficulty there.
Okay, do you have control of the slides?
I do, yes.
Okay, so thank you so much for inviting me to participate in this discussion, we had the pleasure of doing a seminar, a symposium at the STD conference, and it was very useful to understand how STD clinics are thinking about the possibility of PrEP. I'm going to talk mostly about the clinical practice guidelines and the evidence supporting PrEP use, and then turn it over to my STD clinic colleagues. Next slide. So this slide really is just intended to indicate why it is that we feel it's important to keep adding very effective prevention options to our portfolio of measures available. What you can see is that the incidence of HIV infection has been stable for quite a while now, at about 50,000 new infections a year. And although we hope eventually to scale antiretroviral treatment up enough to have an impact on incidence in terms of the prevention benefits of treatment, we haven't yet seen that on a national level. Next slide. One of the new things that we have is obviously pre-exposure prophylaxis. And rather than go through all the different trial results, I just wanted to give you a little bit of background about what we've learned from the different trials. So there have been a number of trials that were done. The IPREX trial was done in men who have sex with men. TDF2 and Partners PrEP were done with heterosexuals at high risk, both men and women. And FemPrep and the VOICE study were done with high-risk heterosexual women. All of these trials were primarily in developing countries, although IPREX, about 10% of its participants were in the United States. What this slide demonstrates is that the modified intent to treat effectiveness, so when you compared all those people who were randomized to receive drug versus those who were randomized to receive placebo, regardless of whether they used it or not, there were a variety of results in terms of the amount of effectiveness that was seen. But when you looked at how that effectiveness was related to adherence in the study to the medication, there was a very clear pattern. And so on the top right, what you see is the IPREX trial, the TDF2 trial, and the Partners trial showed very high levels of participant samples that had detectable drug, indicating that they had recently been taking the drug. And they also showed, therefore, very high levels of effectiveness against HIV infection. And on the bottom left, you see the 3 trials that did not show effectiveness for HIV prevention. And in those cases, the amount of drug detected in participants' blood was very low. So we learned early on that although PrEP can be effective, it's highly related to the adherence to the medication. Next slide. This is another way of looking at the 3 largest studies that showed effectiveness. So for the IPREX trial in MSM, the modified intent to treat analysis showed a 44% effectiveness. However, among those who had drug detected in their blood, it was 92% effective. And a similar pattern was seen for Partners PrEP and even for the IDU trial. The IDU trial did not use a combination antiretroviral. It used the single drug tenofovir. Next. So based on these data and much additional safety and effectiveness data that came out of the different trials, CDC decided, along with its public health service partners like HRSA, FDA, the VA, that it was time to issue clinical practice guidelines for the use of PrEP in the United States, and those were published last month. And in those guidelines, we provided a review of the efficacy and the safety evidence, and then clear guidance to providers about what are indications for PrEP use, what things should prevent people from being prescribed PrEP, and how to prescribe it and do follow-up testing and laboratory testing to ensure that it was safely delivered. There's also guidance on how to support medication adherence and maintaining lower levels of risk behaviors. And last, there's guidance on reporting HIV infection and reporting PrEP use in pregnancy. Next slide. So the key messages from the clinical practice guidelines are that daily oral PrEP using a combination, the co-formulated pill containing emtricitabine and tenofovir that's marketed in the U.S. as Truvada is recommended as one prevention option for people who are at substantial risk for acquiring HIV infection. And that includes the populations for which we have good trial data. So MSM, heterosexually active men and women, and injection drug users. The guidelines also say that PrEP use should be discussed with HIV discordant couples for potential use to protect the negative partner during attempts at conception, and for HIV uninfected women with positive partners to prevent HIV acquisition during pregnancy. In addition, there's a recommendation that the use of PrEP should be weighed carefully for adolescent minors. This is the case because although Truvada is used widely in the treatment of adolescents with HIV infection, none of the PrEP trials included people under the age of 18, and so we don't have specific PrEP safety data for those under the age of 18, although there is a trial underway to get exactly that data. Nonetheless, we recognize that people under the age of 18 may be at very high risk for HIV infection, particularly MSM youth, and therefore we suggest that it be considered carefully before prescribing to them. We also say that it's important for anybody prescribing PrEP to support medication adherence and to support continued risk reduction practices. Next slide. So these tables summarize the recommendations in the guidelines. So in terms of defining which sexually active people, both MSM and heterosexual, may be at very high risk and have an indication for PrEP. That would include HIV-negative people who have HIV-positive sexual partners, those who have recent bacterial STIs, those who have a high number of sex partners, including commercial sex workers, those who have a history of inconsistent or no condom use. And specifically for heterosexual women and men, it's also important to consider that they may be especially at risk if they're in a high prevalence community or network. For injection drug users, next slide. And so one of the things we do in the guidelines is also to provide some tools for clinicians to use. And so in the case of determining whether you're in a high prevalence area, we refer providers to two websites. This one is AIDSview, where it's very easy to get HIV prevalence data for your community, sometimes down to the zip code level. Next slide. For injection drug users, similarly, we think that PrEP may be indicated for people who have injecting partners who are HIV positive, who share injection equipment, or who have been in recent drug treatment but are currently injecting. It's also important to notice that most injection drug users are also sexually active, and so there are times when people need to be evaluated by more than one of these categories. Next slide. So if a person has behavioral indications for PrEP, the next step is to be sure that they are HIV uninfected. This is important because in the trials, the only drug resistance that was seen was in patients who were accidentally started on PrEP when they were in acute HIV infection. So their antibody test was negative. They started on the medication. They came back a month later for their study visit, and they were HIV positive by antibody test. The researchers then went back to the original blood specimen from their baseline visit and were able to determine with NAT testing that virus was actually present at that point. So it's very important to document that people are truly HIV uninfected and do not have signs and symptoms of acute HIV infection before starting somebody on PrEP. Tenofovir in patients with HIV infection has sometimes been associated with decreased renal function, and therefore PrEP is only indicated for people who have an estimated creatinine clearance above 60 and who are not on other medications that can compromise renal function. In addition, we recommend that everyone have a documentation of their hepatitis B virus infection status and vaccination status. PrEP is not contraindicated by people with hepatitis B, but because the drugs that are used for PrEP are also active against the hepatitis B virus, it's important to know that patients may have active hepatitis B infection so that when they come off PrEP at some point, you're aware of the risk of reactivated hepatitis virus infections and resulting liver damage, and can follow that subset of patients much more closely. So if patients have behavioral indications for PrEP and no medical contraindications, then the guidelines call for prescribing a daily dose of Truvada with no more than a 90-day supply. The 90-day supply is an attempt to enforce frequent HIV testing while people are on PrEP. Next slide. This is an abbreviated version of the algorithm in the guidelines for how to exclude acute HIV infection. And we offer clinicians 3 options for laboratory confirmation that someone does not have acute infection. And that includes either, if you have no other resource, to wait a month before starting PrEP and do another antibody test. The problem with that is that people may have additional exposures in that month. The preferred option is to send blood for a 4th-generation antigen antibody assay. And if that option is not available, it is possible to do a viral load test, although viral load for diagnostic purposes is not an FDA-approved test. Next slide. Next slide. Okay. So once you start someone on PrEP, what the guidelines recommend is that you do follow-up visits every 3 months, repeat their HIV test, assess their medication adherence and provide any counseling and support necessary, assess their risk behaviors and provide any support necessary to prevent increases in risk behavior, assess side effects, and if there are any severe side effects, provide clinical management. In the PrEP study, side effects were uncommon. They were, in most cases, transient and cleared within 1 to 2 months of starting the medication. The most common side effects, which occurred at 5% or less of patients, were headaches, nausea, some abdominal pain. Those were the most common things. We also ask that every 3 months you do an assessment for STI symptoms, and if they have symptoms, do the appropriate diagnosis and treatment. At 3 months after starting Truvada, we suggest doing another creatinine, and then every 6 months thereafter. And every 6 months when they come in for care, test for bacterial STIs even if they are asymptomatic. And my computer just decided to go blank. Here we go. Okay, next slide. For MSM specifically, we remind providers of the importance of doing extragenital STI testing. Next slide. And for women of assessing both, or for heterosexual men and women, assessing pregnancy intent, and for women doing a pregnancy test every 3 months. Next slide. And for injection drug users, ensuring that they have access to clean needles and syringes by whatever means are legal and available in the provider's community, and access to drug treatment services if patients are ready to engage in that. Next. In addition to the guidelines document, there is a provider supplement that contains fact sheets for patients on PrEP, Truvada, and acute HIV infection. In the printed form of the guidelines, they are available in English, but on the website, they're also available in Spanish. In addition, there are provider materials like a patient-provider checklist, some information for clinicians who want to counsel patients about PrEP during conception, pregnancy, and breastfeeding, a behavioral screening index that was developed at CDC for MSM, some potential quality measures, and some supplemental counseling information. Next slide. Turning to implementation a little bit from the guidelines, one of the things that has been brought home to us is that in addition to the kind of cascade that we're used to dealing with treatment that focuses on things from a patient's point of view, we don't have a cadre of ready providers out there who are trained and ready and willing to provide PrEP. And so in order to have the appropriate patients seek care, we have to develop a set of providers who are ready to provide that care. Next slide. The potential PrEP providers are those clinicians who are seeing HIV-uninfected people who are at substantial risk for acquiring HIV infection. And so in addition to STD care providers, that includes primary health care providers, drug treatment providers, and in some cases HIV care providers, particularly where those providers see both HIV positive and negative patients. Next slide. This is data that I'm sure everybody on this screen knows really well, but this is the kind of data that leads us to believe that STD clinics are a very appropriate place to consider delivering PrEP. This study in New York City that linked records from STD clinic and the HIV care registry were able to show that those MSM who had any evidence of gonorrhea or chlamydia rectally were at higher rates for acquiring HIV infection than those without, although those without, particularly African and American and Hispanic, were still at very elevated risk for acquiring HIV infection. Next slide. In addition to the guidelines and the supplements, CDC has generated some other materials and is working on some additional ones that will be helpful to clinicians. There is a pamphlet in English and Spanish online for how to talk to your doctor about PrEP. There are, as I said, the MSM risk screening tool is in the guidelines. We also have in development right now one for injection drug users and for HIV discordant couples. Those are in the process of being turned into a digital format that could be used on a computer screen or a cell phone app. And then we're developing a guide for billing for PrEP-related care. Next slide. One of the most common issues that people consider a barrier to PrEP use is how is it going to get paid for. If you were to pay for PrEP entirely out of pocket, you're talking about nearly $1,400 a month just for the medication costs. However, PrEP is covered by most private insurers and by many public insurers, for example, Medicaid. And there is medication copay assistance available. For those people who have a low income and either no insurance or their insurance declines to cover PrEP, Gilead Sciences has set up a medication assistance program that will provide free drugs to the provider for those patients. They also, on their website, will provide free condoms to the patients and vouchers to providers for HIV testing and hepatitis B screening, as well as HIV resistance testing for those who seroconvert while taking PrEP. Washington State has recently set up its own drug assistance program specifically targeting PrEP. Next slide. So the next step after completing the clinical trials has been to try to understand how this is going to work in what people call the real world. And this has been approached in a kind of stepwise fashion. So open label extension studies have been done in the United States. The one is the IPREX trial for MSM, has an arm of its open label extension here. And this is where patients who were in the original clinical trials are told the results of the trials, and then all the patients, whether they're in the placebo arm or previously in the active arm, are allowed to have access to PrEP. We should get results from the IPREX open label study later this year. The next level is demonstration projects where people are recruited who weren't in the trials into a research study to try to understand what's the acceptability and what's the use of PrEP in those contexts. And I'll show you the results of one of those, preliminary results. And then the closest to actual practice is what we're calling implementation pilots, which is doing evaluations of patients who are receiving PrEP as a clinical service in their own communities. This is more akin to health services research. Next slide. So NIAID funded a demonstration project in 3 STD clinics, one in Miami, one in San Francisco, and one in the District of Columbia, where patients were offered PrEP as part of a study in which they received extensive counseling and they received, their adherence was measured by drug levels in the blood. This test is not FDA approved. This is a research-only test, unfortunately. And so what they found when they looked at patients through 4 weeks of PrEP, if you look on the left, the rates of drug levels in the blood that were consistent with daily doses were lower than we would have hoped, and they were not the same across all 3 sites, even though all 3 sites had the same protocol. On the right, however, they had done an additional study in which they did directly observed therapy with patients, and they put them on several different dosing regimens. So some came in every day, some came in twice a week, some came in 4 times a week to get their directly observed therapy. And then when they reached steady state, they looked at how much drug was in their blood, and then they compared that to patients in the IPREX study who had that level of drug in their blood to see what the protective effect was. What they were able to show was that 4 or more doses per week was associated with a 96% protective efficacy. And so on the right, you see that, in fact, the majority of patients in this demonstration project had taken 4 or more doses per week, even though they may not have taken them daily. and so achieved 3/4 of them across all sites achieved a high level of protective effectiveness. Next slide. So that's the evidence, and that's where we are in terms of implementing at the moment, particularly in an STD clinic setting. And now I will move to Dr. Thrun's talk.
Thank you, Dr. Smith. Actually, the next presenter is going to be Dr. Flash.
Okay.
So thank you. Dr. Flash is a physician scientist in Houston, Texas. And Dr. Flash has launched a comprehensive HIV prevention clinic where HIV pre-exposure prophylaxis is prescribed and non-occupational post-exposure prophylaxis and PrEP is also provided to high-risk heterosexuals and high-risk MSM. She also provides primary care to patients with HIV at the Thomas Street Health Center in Houston, Texas, and consultative services at the Ben Taub General Hospital. Dr. Flash's research investigates HIV prevention, testing, and linkages to care in underserved communities. So Dr. Flash, whenever you're ready, you're up.
Thank you for that kind welcome and for inviting me to participate on today's webinar. Today I'm going to talk a little bit about HIV pre-exposure prophylaxis from a provider's perspective. Next slide. Hello? Oh, great. We'll touch on 3 elements: provider perspectives, a little bit about our local experience with PrEP, and then a slide on additional resources in addition to what's been shared from the Centers for Disease Control. Next. So just to set the scene, as many of us at our STD clinics and HIV clinics have patients in mind, I'd like to present a short case. So Mike is this 25-year-old recent college graduate who is in a 3-month relationship with 30-year-old Ben. They are at home, and he pulls a shoebox out from under the bed with pill bottles in it. This is a true story. Ben says to Mike, "Well, I've been meaning to tell you, but I am HIV infected." Next slide. So it is scenarios like these which many of us who provide clinical care or take care of patients that have been infected with sexually transmitted infections or are having frequent sexually transmitted infections are presented with on a weekly basis, if not a daily basis. And as we consider why is this important, we recognize that particularly for the gentleman in the scenario that I described, that if one is having unprotected receptive anal intercourse, there are 50 infections per 10,000 exposures to HIV, assuming no condom use. And so for this particular scenario in which we know one of the partners was HIV infected, it raises our concern about the potential for infection. But also there are many people who are engaging in sex with people who they don't necessarily know what their HIV status is. Next slide. Now, as providers, one of the key questions that I hear when I talk with providers is, well, why not get Ben into care? Why not get the HIV-infected participant into care? They cite this trial, which I'll tell you a little about. In 2011, it was considered the Science Breakthrough of the Year. It was HPTN 052 through the HIV Prevention Trials Network. It was a randomized controlled trial of over 1,700 couples who were in relationships in which one person was HIV infected and the other was not, a serodiscordant or a serodifferent couple. The participants were recruited from Africa and Asia and the Americas. And what they did is these were areas of the world where people generally were not initiated on HIV medication until their CD4 count was less than 350 during the time frame of recruitment for the study. However, they decided they would start HIV treatment early for a proportion of these patients to see, if I start HIV treatment a bit earlier than I normally would, will I be able to protect their uninfected partners from actually contracting HIV? And what they found in this trial was that there was a 96% decrease in the sexual transmission of HIV for the uninfected partners in this trial. Next slide. So as we see, getting Ben, the HIV-infected partner, is a very important aspect of HIV prevention. So one might ask, however, why do we need anything more? So even in this trial, this treatment as prevention trial, we found that 11 of the 39 people who started out HIV negative and ultimately became HIV infected by the end of the trial, for 11 of those people, they acquired HIV from people outside that primary sexual partnership. And so we see that we could get Ben into therapy all we want. However, if Mike is having other sexual partners, his protection will not be complete. So we find that treating infected partners may not provide complete protection for people who have other sexual partners. Next slide. Another reason that we need more than just the important focus on treatment is that many new HIV infections occur in the context of acute HIV in times when the infected partner might not be aware that they're actually infected. In this scenario, Ben was aware that he was HIV infected, but many times the partner may not be aware. And then they might continue to engage in behaviors that are likely to transmit HIV to others just because they're unaware of their status. So that leads us to the concept that we need something additional for vulnerable people, and that brings us to PrEP, not as an end-all and be-all of HIV prevention, but as part of our national strategy towards decreasing HIV infections in the United States. So as Dr. Smith described in great detail, we have one FDA-approved drug that can be used for the purpose of prevention. It's taken on a daily basis to prevent HIV. We emphasize to patients that it's not a morning after pill or a morning before pill, but something that should be taken on an ongoing basis to achieve appropriate levels of prevention. Efficacy ranged from 44 to 67%, but if taken perfectly, it can be 92% effective, and as Dr. Smith was describing, even as high as 96% effective. However, despite all these data that we have in clinical trials about effectiveness or efficacy, PrEP uptake in the real world requires that potential providers be both knowledgeable and willing to prescribe or refer. Next slide, please. So to look a little bit further at that portion of the conversation, I'd like to share with all of you some data that we collected locally in Houston on primary care providers in our jurisdiction. Now, of course, these findings may not generalize to all providers throughout the country, but I use it as an example just to highlight some of the thoughts and concerns of providers. Between January and April of last year, we conducted an anonymous online survey among healthcare providers in Harris Health System, which is the largest network of public primary care providers in the state of Texas. Comprises 22 locations staffed by clinicians affiliated with 2 universities, either the Baylor College of Medicine or University of Texas Health Science Center. Amongst those 22 locations, one of the locations is the Thomas Street Health Center, which provides primary care for HIV-infected patients. So participants on this survey who stated that they provided care there will, for the purpose of this conversation, be denoted as HIV specialists because that's the population to whom they provide care. There were 210 participants in this survey with a mean age of 36. Most of the respondents were female and 48% were white. Many other racial and ethnic demographics were represented on the survey, and you see the subspecialty breakdown at the bottom on the right there, with most of the respondents being internal medicine providers. However, a fair number of those who were family practitioners or infectious disease specialists who primarily did primary care, or obstetricians and gynecologists, or combined boarded internal medicine and pediatric providers. Next slide, please. So first we asked providers whether they thought that PrEP had been proven to be safe and effective. And we found that 40% of the providers surveyed were uncertain whether or not PrEP had been proven safe and effective. Of the providers surveyed, HIV specialists were much more likely of believing that PrEP had been safe and believing that PrEP had been effective. So that was the first challenge identified, that the level of knowledge in the community needed some building. We then asked patients if they participants, if they felt as though they were confident in their ability to actually identify patients who could benefit from PrEP, patients who were vulnerable to HIV infection. And only 40% of respondents felt confident in their ability to identify patients. Now, the HIV specialists had a 4 times greater odds of being confident in their ability to identify patients, but therein you see a challenge, as these HIV specialists were providing care at a place where they primarily see HIV-infected patients. So they are not exposed to the most at-risk people, who are the uninfected participants in the community. Next slide. Now, we then asked providers, would they be willing to refer or to prescribe PrEP if they received the appropriate training, with a nod to the fact that many of them felt as though they didn't have adequate knowledge on PrEP safety and efficacy. And we found that 94% of providers stated that if they received the appropriate training, they would be willing to refer patients, and 86% said that they would be willing to prescribe PrEP if trained appropriately to do so. Now, even more interestingly, very few of these providers, only 18%, stated that they had received a patient inquiry about PrEP. However, they noted that 80% noted that if they did receive an inquiry about PrEP from a patient, then that would motivate them to prescribe. Next slide, please. Now, despite this percentage in the 80s to 90s of providers who would be willing to prescribe or refer, we still found that 60% of primary care providers in this publicly funded setting preferred PrEP be managed by a specialist of some sort. Next slide, please. Now, another question that often comes up when we discuss PrEP is whether or not the addition of PrEP to our HIV preventive arsenal will promote risky behavior. This concept of risk compensation, where people wonder whether there will be sexual disinhibition or a reduction in the use of condoms as an adjunctive safety measure if someone has this additional tool. Now, 29% of the surveyed providers believed PrEP might promote risky behavior. What the data shows is that in the clinical trial realm anyway, of the 5 clinical trials that were presented to you earlier, there was actually a trend toward decreased sexual risk behavior. Now, the caveats to this, of course, are that that was a clinical trial setting, that participants were self-reporting their risk behavior, and that it was coupled with behavioral interventions. Next slide, please. I present this information to highlight a couple of key features. That first, we have a need for additional training for providers to enhance not only their knowledge of PrEP safety and effectiveness, and that would fall in line with webinars like today to allow providers to feel equipped with the tools they need to be able to understand whether or not PrEP is safe and effective, but also to give providers the ability to identify potential patients, to enhance their confidence in PrEP prescribing or PrEP referral, as the case may be, and to enable providers to develop a willingness to engage patients in the use of PrEP and the conversation about the things in their lives that might make them vulnerable to HIV. This data also highlights a potential role for a referral-based process. Now, the concerns about safety and effectiveness and about risk compensation, or this increase in risk behavior, is an important one that also needs to be addressed. But we see that this is in the context of patient influence. And we see that only very few providers received inquiries from patients about PrEP. However, the majority of them would be motivated by patient requests. And so this drive for PrEP from the patient population, I think, will be a very important feature as we move forward. Next slide, please. So now that we've looked a little bit about what at least our local providers are thinking, I bring us back to our case. So Ben brings Mike to our comprehensive HIV prevention clinic at Thomas Street Health Center in Houston, Texas, where we provide a comprehensive HIV prevention tools to patients, which include pre-exposure prophylaxis where appropriate, or non-occupational post-exposure prophylaxis as appropriate, condom education and free condoms, as well as getting the HIV-positive partner in care. Next slide, please. Now, as we've rolled out the prescribing of PrEP and the assessment of patients for PrEP in our community, one of the things that we've recognized is the important link between ramping up HIV preventive strategies and HIV testing. And so when patients present for walk-up HIV testing in our health system, they receive, as they're having their counseling and testing session, if they're identified as not high risk, then they receive routine counseling and testing. However, for those participants who are identified as high risk, they receive additional counseling that gives them more than just the routine preventive messaging, but really gives them information about HIV pre-exposure prophylaxis as well. Next slide, please. And for patients who state that they have an interest in learning more about PrEP, then we more rigorously look through whether or not they are someone who's not just nervous, but actually vulnerable to HIV. And that patient then undergoes a medical assessment with a clinical provider. If the patient and provider, their assessment reveals the patient is PrEP appropriate and the patient and provider are comfortable with prescribing, they move forward. But a key aspect of this multidisciplinary approach is to also ensure that that patient is availed of adherence counseling. And it involves pill counts after that first month of prescribing, but also individualized counseling, not just about pill taking, but also about navigating conversations about risk with their partners, as the case may be, condom education, and things of that nature as well. Next slide. Now, there are many sites in the country where PrEP implementation focuses on our most at-risk and most vulnerable population in the United States, which are men who have sex with men who are having unprotected, insertive, or receptive anal sex. However, in our region, we also noted that there are men and women who are in serodiscordant relationships or relationships with someone who's known to be HIV positive who indicate that they're not always using condoms, and also other high-risk heterosexuals who might have a recent history of trading sex for money or housing or whatever the case might be, or having multiple sexually transmitted infections or multiple partners who in this high incidence setting might also be potential candidates for HIV pre-exposure prophylaxis. Move forward. Okay. So with that, we have started to incorporate PrEP education into our routine counseling and testing for high-risk individuals. And we're able to collect patients from people who either self-refer at the time of HIV testing or people who are referred by providers in the community, whether that is the provider who's taking care of an HIV-infected person or someone in the community who discovered that their patient was having high-risk behavior and could avail themselves of something additional, or counselors in the community or other staff members. We are also in the process, as I think about this particular group of STD clinic directors, we're in the process of establishing a protocol for formalizing referrals from our STD clinics within the Houston-Harris County region. Our STD clinics fall within our health department system, and so we want to formalize the referral process so that the health department can then have a sense of how many people are being referred from STD clinics as opposed to having people self-refer or having more informal referrals, which is what had been taking place previously. Next slide. So Dr. Smith has gone through this in great detail in terms of what the ongoing assessment looks like, but for us, comprehensive prevention means linking HIV-infected sexual partners in care, confirming that the person at hand is indeed HIV negative, monitoring their kidney function, screening for hepatitis B, giving the appropriate follow-up, which at times is individualized to the patient depending on what the level of chaos is in their lives and what kind of support they might need in terms of adherence and risk reduction counseling, screening and treating for sexually transmitted infections, and providing condoms as necessary. Next slide. Now, in addition to the wonderful resources that have been recently provided by the Centers for Disease Control, there are additional resources that I would like to make people aware of with these three websites, the projectinform.org, prepfacts.org, and whatisprep.org. Some of these have videos and other pamphlets that can be ordered that provide PrEP information. Many of the resources here are targeted towards men who have sex with men, but there are others that target high-risk heterosexuals as well. And so these tools are things that as you explore you might find helpful for not only educating and providing information to potential patients, but also to potential prescribers and community-based organizations in your jurisdictions. Next slide. Last, as I close, I'd just like to acknowledge the staff at Thomas Street Health Center and our comprehensive HIV prevention clinical team, the research team who helped with the provider survey, our study participants, Camden Hallmark from our health department, of course Mark Thrun, who you will hear from next, and the funders for our research. Thank you for your time.
Thank you, Dr. Flash. As you said, our next speaker will be Dr. Mark Thrun, who is currently the Director for the STD HIV Prevention and Control Program at the Department of Public Health in Denver, Colorado, the Director of the Denver Metro Health STD Clinic, and an Associate Professor of Medicine at the University of Colorado School of Medicine, as well as the Director of the Denver STD HIV Prevention Training Center. He sees patients in the STD, infectious disease, HIV, and TB clinics at Denver Health. His primary research interests have included acute and early HIV infection, screening for HIV and STD, engagement in care of persons living with HIV, and the prevention of HIV and STD infections, including the prevention of HIV and STD transmission. Dr. Thrun also advised the CDC on PrEP and the recently released PrEP guidelines. So with that, please, Dr. Thrun, whenever you're ready.
Great. Thank you, Stephanie. I appreciate the invitation to join this call. It's always nice to go last because I'm just simply going to underscore some of the things that both Dr. Smith and Dr. Flash very eloquently presented. And I'm going to try to do so with a spin towards STD programs. So if you could move on to the next slide. So what is the role of the STD program relative to PrEP? Well, I would argue there are multiple reasons why we in STD should be thinking about PrEP. One is that we know who will get HIV, sort of. Dr. Smith has already presented some information. I'll present one more slide, a couple more slides, in fact, that make a nice case for the fact that, indeed, the folks that go on to get HIV have probably been seen by one of us in one of our programs at some point in the past. Within the sexual health and STD program arena, sexual health conversations are already normalized. Clinicians and staff are very knowledgeable and comfortable talking about prevention modalities and developing prevention plans with their patients, with their clients. Patients are oftentimes already primed for a discussion of risk modification because they're already seeing us for treatment of their STD or being seen by us to identify their partners who might have been exposed to an STD. And then, of course, there's a natural link to clinical interventions, including additional HIV screening, STD screening, and hepatitis screening. Next slide. This Venn diagram was developed by one of my colleagues here in Denver for a different purpose. The largest circle in this Venn diagram is the U.S. population. The smallest circle are those that we think remain undiagnosed with HIV in this country, and then that middle circle are those that are recommended to be tested for HIV, all adolescents and adults in this country. Next slide. I would argue, though, that the folks that are truly at risk for HIV are probably much smaller than that large universal target for HIV testing. We don't exactly know the numbers. It was fun last week to be at the STD Prevention Conference and hear several people present on estimates of what that number might be. Next slide. But indeed, most likely this is a moving target, that people come in and out of risk on a regular basis, that they're not always consistently at risk. Perhaps they end a relationship or move into a new area and put themselves at increased risk for HIV and STDs. Next slide. But I would argue that though we don't know who those folks are, or the absolute number of those folks very well. They are oftentimes our STD clinic patients, our DIS clientele, and folks that end up somehow in our disease registries. Next slide. In addition, if you think of just who's being seen by our STD programs, this is just a slightly updated version of a slide that Dr. Flash presented looking at the risk of HIV transmission per act. The folks that we tend to see are those folks that are participating in anal, vaginal, and oral sex. And so those are the folks that end up being diagnosed with an STD, and perhaps some of them will go on to develop HIV. Next slide. Dr. Smith presented this data in a different manner, but this again was a study of the link between rectal bacterial infections associated with subsequent risk of HIV. These were men who have sex with men who were diagnosed with bacterial infection, most commonly chlamydia and gonorrhea of the rectum, and those who actually had a rectal diagnosis went on to develop HIV much more readily than those who were not diagnosed with a rectal STD. And so indeed, those folks that we're seeing in our STD programs are the ones that are likely to go on to develop HIV. Next slide. I know many of my colleagues who run STD clinics argue, and I've done this at times in the past, that we're not a continuity clinic and perhaps PrEP is not best offered out of our clinic, but I would argue that data suggests that perhaps we might not be viewing ourselves correctly. This is just data from our own STD clinic in Denver. We went and asked patients, we did a survey of a little over 1,000 folks over the course of the last year, primarily about health insurance and trying to evaluate what would happen in the era of the Affordable Care Act. But we asked patients, these 1,000 folks who were being seen in our STD clinic, did you go get sexual health care previously within the last year? And when you did, where did you go to get that sexual health care? And indeed, the first set of bars there, the Denver Metro Health Clinic, is my STD clinic. And so a good 25, almost 30% of folks had actually not only received sexual health care in the last year, but had actually come into my clinic to receive it. And so though we may not think of ourselves as continuity clinics, we certainly see a large number of people repeatedly. Next slide. And indeed, this is just data suggesting how insurance patterns, coverage patterns have changed between the end of last year and the beginning of this year. And we are seeing fewer uninsured folks. Colorado is a Medicaid expansion state, so we're seeing more people covered by insurance. That's that red bar is a survey completed in the end of March. And a few more folks covered by private insurance. And so obviously there are costs that are related to the implementation of PrEP, and we're seeing more folks that are covered with insurance in our STD clinic programs. Next slide. So many of us are already familiar with non-occupational post-exposure prophylaxis that's already been referred to. We identify those at risk for HIV. They've obviously, for PEP, they've had a very recent risk. We screen them for STDs and HIV. We educate and counsel them about HIV risk. In many of our STD clinic settings, we prescribe them post-exposure prophylaxis. In many STD programs, DIS may refer these folks to clinicians where they know a patient can get PEP. And then we follow up. We typically in-house follow up at 1 and 3 months for repeat screening. Next slide. Well, the transition to PrEP I don't think is all that different. We have to identify those folks at risk for HIV. In this case, it's likely folks with recurrent risk or a concomitant STD. We screen them for STD and HIV. We educate and counsel about HIV risk. We prescribe pre-exposure prophylaxis, and we follow up for a little bit longer, obviously, in an ongoing manner. The boxes just represent the slight differences between PEP and PrEP, and I don't want to minimalize. I know there's a little bit more logistically to the difference between PrEP and PEP, but indeed, in theory, it's not a whole lot different than what we do in PEP. Next slide. What we do in Denver is very similar to what's being done at Thomas Street Clinic. Our own processes in our STD clinic is that either a patient self-refers or is identified as a potential candidate because they've had repeated PEP, because of repeat STDs, because of their reticence, because they declare a reticence to use condoms or recent high-risk behavior. We perform HIV and STD screening in our clinic. We have folks meet with a prevention counselor. Next slide. Indeed, we leverage our own linkage to care staff for that role. Patients are fiscally screened. They meet with a clinician. Typically, we leverage some of our HIV clinicians that we happen to have on staff here to sort of meet more formally with the patient that is interested in pre-exposure prophylaxis. We also are able to leverage our own pharmacy that we have on site, which is incredibly useful because they are a Ryan White funded pharmacy. They're very familiar with the HIV medications and the indications for both NPEP as well as PrEP. And then we have prevention counselors on site that we're able to leverage for ongoing questions. And then patients are prompted for the repeat visit at 3 months, and then we continue to follow them up every 6 months for STD screening and counseling. Next page. How did we get there? We actually began by just identifying clinicians that were very interested in PrEP. This, I think, is really important for STD program directors in all the jurisdictions, in many jurisdictions, maybe not all quite yet, but in many jurisdictions, I suspect there are clinicians that are interested in PrEP. We use those clinicians to help us develop a protocol. Part of it was sort of a sales. Part of our protocol was sort of sales by presenting some of the data that Dr. Smith has presented to try to educate our providers. Dr. Flash gave some nice data on the fact that though providers may be willing, many of them don't necessarily feel as if they have the tools or knowledge yet to implement PrEP, so we wanted to make sure our protocols covered that. In addition, we followed procedures. This is mostly taken out of the PrEP guidelines from CDC. And then we inserted some potential billing codes so people knew, so providers knew how to bill appropriately, and included some case scenarios. We did engage our linkage to care and our prevention counseling staff as sort of adjuncts for our medical providers so that they felt they had additional support should the client have additional need. And then we started by talking, we then started by talking with community members about who might be at risk and who might be partners of people living with HIV, and indeed have grown our PrEP clinic from there. Next slide. I would say, though, that there's other potential roles for STD programs. One, and perhaps most important, is just simply compiling and disseminating risk data profiles. Those of you on the call know that we in public health collect a lot of data really well, but we don't always turn that back around in a digestible manner for communities, and so a lot of people in communities don't know that they're necessarily at risk for STDs and HIV still. I think that there is a role for, even if you don't develop a PrEP clinic or prompt one of your fundee, your grantees to develop a PrEP clinic, there's still a role for STD programs to market to the community, to educate the community about PrEP. There's some lovely data that have not been shown here that though many MSM identify that they know of PrEP, that perhaps when you dig a little bit deeper, they don't really know as much as they think that they know about PrEP. Clearly there's a need to educate providers, as Dr. Flash has pointed out, and that could certainly be a role of STD and HIV programs, both at the state and city level. Developing resource lists, a provider directory, or educational kits for patients or for providers around PrEP, I think are all potential roles of STD programs. And then obviously thinking about how to evaluate at the jurisdictional level the efficacy of PrEP, I think is certainly a role for public health. Next slide. There are some remaining questions that I think we should engage in with our HIV providers, with our primary care providers in our jurisdiction, with our HIV prevention colleagues. How can we continue to more objectively and effectively identify those at risk who might benefit from PrEP? The CDC guidelines have a lovely tool, in fact, for MSM that I think is great, and thinking about how to implement that or how to educate providers to use that more readily, I think would be a great role for public health. How do we best educate the community? How do we best market PrEP to a population that might be at risk and might significantly benefit from PrEP? How do we not create a tiered healthcare system? How do we make sure that PrEP is available to folks? How do we make sure we get the word out about the Gilead patient assistance programs and other resources that might be available? And then could we think about how we use our own STD DIS staff or prevention staff to help support providers that might be interested but just leery of sort of what might be involved. I think there's lots of potential for leveraging DIS staff and other STD and HIV supported staff at the jurisdictional level to help support providers so that they feel like they're not alone in this. Next slide. There are obviously still barriers to overcome. I won't emphasize these because I've already talked about them, but clearly patients need to be educated, providers need to be educated, and indeed many of us as statewide and jurisdictional programs need to think a little bit more thoughtfully and in a structured manner about PrEP, and hopefully you will after this webinar. Happy to answer questions moving into the future. Next slide. There are lots of resources that are available. These were the interim guidelines, though I'll quickly go through these. Next slide. These are a couple other additional resources, including the REMS information, the Truvada REMS information that providers would need to be aware of as they're prescribing PrEP. And then finally, the PrEP guidelines that came out from CDC on the next slide, just released in May. These are actually a lovely tool, very comprehensive with an enormous amount of data backing up why PrEP should be considered, and then the provider tools that come along as an appendix to the guidelines are incredibly powerful and very helpful. And I'd encourage STD programs to flip through these to see that there are a large number of resources that one could already be pointing to providers to help continue to educate them. And so with that, next slide, I think public health does, and we in STD programs play an ideal role as a connector between parts, between providers and at-risk persons, between what we're already doing in prevention and screening programs, and obviously the data that we collect in HIV and STD programs. We really can help facilitate and share amongst these different domains to help facilitate that people think about PrEP, the providers that are interested but may not feel as if they quite have the tools. I think we can continue to move PrEP in the right direction. Next slide. And so I really do think that STD programs can increase the feasibility of PrEP. Clearly, STD clinics and DIS encounters are ideal for finding people who might benefit from PrEP. STD clinics potentially could be places to even implement PrEP and to provide PrEP. STD clinicians and DIS are ideal for counseling about PrEP because they're already thinking about prevention modalities and helping people develop PrEP prevention plans. But then I think we might need to help in our jurisdictions think about the logistics. How do we refer to providers if we're not able to implement a program or we don't have an STD clinic interested in implementing a program? How do we then develop a list of providers that might be able to provide PrEP? We need to help our providers think about the ability to bill. There's nice resources in the CDC guidelines about how to bill and very specific coding data. We need to think about laboratory support. Not all STD clinics will be able to do labs. Obviously, not all STD programs can check renal function, for example, and so thinking about how to bridge those relationships and develop those relationships to help people in being able to do that. And then finally, at the jurisdictional level, again, how to monitor and evaluate. And so with that, I'll end, and happy to come back to this if questions arise, but I'll just finish with that thought. I do think that we in the STD program role, we in the public health role, can truly help facilitate PrEP along a spectrum from thinking about delivering it ourselves through grantees or our own programs to thinking about what are the other ancillary supports and relationships that are going to need to be developed and grown to help implement PrEP. And thank you again for the opportunity to speak.
Great. Thanks, Dr. Thrun. So now we have some time for questions or comments to our speakers. As I've been saying, I have muted all the non-speaking lines, so if you have a question, please do enter it in the chat box, to the left of your screen. I have been collecting a few questions that have arisen as the presenters were speaking, so I might start with one question that's in regards to the acute case information provided by Dr. Smith early in her presentation. The question is, if viral load tests aren't FDA approved for diagnostic testing, how does this affect surveillance guidelines that accept detectable viral loads as case confirmed? Many providers use viral loads as a diagnostic tool.
So did you want me to answer that?
I think you will be the best for the first crack at it, yes.
I think for confirming HIV infection, viral loads are appropriate. It's for diagnosing them in the first place that it's not FDA approved. So the major reason that we do viral load testing in a person who is antibody positive or fourth-gen antigen positive is to understand their viral load before they start treatment. It's to confirm a diagnosis. It's not to establish a diagnosis.
Okay, great.
Can I comment on that?
Please.
As well, that when you look at a person and you wonder, have they been acutely infected, and you don't have any other tool in your arsenal, we often will turn to a viral load to see whether or not the person has circulating virus. Although it has not been approved by the FDA for the purpose of diagnosis, whether you want to call it diagnosis or not, it provides a caution sign for you. And so you would not prescribe PrEP for someone that had a positive viral load. Now, the reason that I think we also highlight that it's not a good tool for diagnosis is one of the populations for whom people are considering PrEP are the frequent peppers, right? So people who get post-exposure prophylaxis on a recurrent basis, and whether or not these patients should then be transitioned to PrEP. Well, if someone has just come off of a full treatment regimen for post-exposure prophylaxis and you try to confirm their status using a viral load, perhaps they could be suppressed by the regimen they were just exposed to. So with that, you can't say that a viral load is something that, even if you're using it off-label, it doesn't make sense to say that that's a diagnostic tool. It is something that is in your arsenal that you use along with your clinical assessment of the patient.
Great, thank you both. It's very helpful. I'm going to give a few minutes for folks if you have additional questions or any comments to enter into the chat function. I think those were most of the questions we received. I did get it through the chat function, yes. All right, well, it seems like we don't have any additional questions at this time. So again, I would like to thank you for joining our webinar today. And again, I would like to give another thank you to our three presenters, Dr. Dawn Smith, Dr. Charlene Flash, and Dr. Mark Thrun for taking the time out to present today. And again, another thank you to Jenny Sewell from the Division of HIV AIDS Prevention for helping me gather the speakers and putting together the logistics of today's webinar. As I said, the slides and the webinar recording will be available after this webinar on NCSD's website, and I will make sure that all attendees receive an email with that information. And if you have any additional questions that come up and you'd like to get the information for our speakers, you can also email me. And my email is s&stephanie, ARNOLD@ncsddc.org, and I'll make sure your question gets to our speakers as well. So with that, I'd like to thank you all again for joining us today. Have a good day.